Open space is obviously very good to get people talking. If you weren't here yesterday, I'm Sheila Young. I'm one of the directors of Nourish. If you were, hello again. I'm here to introduce the speakers again this morning. We have three fantastic witnesses looking at food and public health. I have a couple of bits of housekeeping. There will be a fire alarm test today at 1:15, so we should be at lunch at that time, so you don't need to zoom out, it is just a test. If it goes off at any other time, obviously it isn't. Fire escapes there and there when you're in this part of the building, and loos I hope you found already, but there's some to the left as you go down the corridor, and there's some to the right, just to the right of the lecture theatre. So welcome back everybody. I've had a fantastic time in the open space this morning, doing what Pete reminded us this morning is thinking about transformational change, not incremental change. And I think when we go back into our groups later on, thinking what would really transform the food system in Scotland is the real challenge. It's not what little tiny tweaks we can make. What would really make the positive changes we want to see, the transformational changes. So that's something to bear in mind for later on. We're here in this witness session, it says here till 11 o'clock. I will be jabbing the speakers with my pointy ballpoint pen if they overrun, because we don't want to skimp on your discussion time later on. So my first speaker I want to introduce is Professor Annie Anderson. She researches interests that focus on factors that are to do with food choice, dietary assessment methodology, and the impact of dietary selection on human health. I'm not going to go on too long now because she says she's got 40 slides, so she's under the cosh.
Thanks very much, and thanks very much for inviting me to speak this morning. Okay, I have got a lot of slides. That's interesting, yes, I still need to see the screen. Okay, I have got a lot of slides, and I'm only going to talk about the top line on the slides. They will be available, so don't scream because you can't read the detail, because it's probably going to be quite useful to go back through it. Okay, so this one? Yeah, okay. So I'm going to talk about some health and disease-related factors to kick off. So this slide, first of all, looks at obesity in Scotland. And the point that I want to make is for both men and women, obesity is very common. It's about 66% of the population overall. But if we look at men, aged 45 to 54, 55 to 64, and beyond, it's about 80% of Scottish men are either overweight or obese. So it's a common problem. And medical complications of obesity per se, I'm sure you know, heart disease, diabetes, and we've got about 4% of our population with type 2 diabetes, but it's expected many more. A whole range of systems are affected by obesity. And that's before we go on to think of other diet-related disorders. And the cost of obesity was estimated in 2007-2008 as in excess of 457 million. So when we're talking sums, and I know Pete asked me to put some sums on the table, that's just obesity and its related costs alone. Obesity relates to lots of disorders. The disorders that I'm particularly interested in is in relation to cancer. And for a long time it's been recognised that next to smoking, obesity is the main modifiable risk in relation to cancer. Now I should say, for all the diseases, or virtually all the diseases that we're talking about, we're really talking about a genetic environmental interaction. We come with our genes and with our family history, and we can't do much about that. And we will have some degree of risk for different diseases. But when that disease is triggered, and if it's triggered, will depend on our environment. And our environment is our wider, the way we lead our lives. And so it's not, diseases like cancer aren't just due to environment, but the environment we can do something about. When we look at bowel cancer, one of the most common cancers in Scotland, what we know about what the risk factors are, and we reckon it's about, well, it's actually probably more than 43%, are related to these lifestyle factors. And that's even before we look at smoking. Foods containing fibre, so whole grains, beans, pulses, we eat far too little of them. Red and processed meat, we eat too much. Alcohol, we consume too much and we're inactive. And then there's obesity on top of that. So it's not that we don't know these factors, and that's before we might start to look at a range of other things. With breast cancer, there are 3 environmental factors that we know are related to significant proportions of cancers. But yet, when we ask people what they think causes cancer, they say it's fate, it's stress, it's worry. So we're not even making the connection for most people between diet and disease. Now, one of the things that we do is run something called the Scottish Cancer Prevention Network, which is trying to raise awareness about diet and lifestyle and cancer risk. And this, we run quarterly newsletters, which anyone is welcome to sign up for. If you go on our web there, you'll find out how to do it. And the more people we have interested in cancer prevention, the more that we can say we actually want to do something about the diet and the way that we live our lives. Most of the stuff that we produce is focused at health professionals, because sadly, most doctors and nurses and most health professionals are virtually unaware of the relationship between lifestyle and cancer, both in terms of the development of the disease and in terms of the management later on. But just some other slides to get a message over about ill health in Scotland. Morbidity, rather than talking about major causes of death. The majority of over 65s have 2 or more health conditions, and more people have 2 or more conditions than 1. And this is a little complicated graph, but it just shows that most people with any long-term conditions have more than 1. So if people are diagnosed with hypertension, they probably have coronary heart disease. They're more likely to have heart failure. If they have cancer, they possibly also have coronary heart disease. So it isn't just that people have 1 condition. We live in a society of a huge morbidity. They are complex, they're interrelated, and we know that food plays a factor in them. A number of people in Scotland who are multi-morbid have got more than 1 condition, and under 65 and over 65. So these aren't diseases of old age. These are diseases that present as we go through adult life, and so on. When we look, coming back to obesity, when we look at what we know about determinants of weight gain, at a convincing level, we think physical activity is important, but at probable level, when we mount up the dietary factors, then really we have a very clear picture. Energy-dense foods, sugary drinks, fast foods. Fast foods, this is data from England. I haven't seen any data on this in Scotland, but it's fast food outlets by index of multiple deprivation, and that's what the graph is here. So the higher deprivation, the higher likelihood it is that we have fast food outlets. Can we replace fast food outlets with something healthy, please? What is energy-dense foods? Well, I don't need to give the definition, because we just need to look to see what's marketed, and it's illustrated for us, isn't it? And why? What are the bigger reasons about obesity? Why is it that we eat more? This is from a slide from Boyd Swinburne's work, in which I think summarises it. We've got an increased supply of cheap, palatable and energy-dense food. We've got access through our distribution systems to that food, and we have persuasive and pervasive marketing. That's not something, of course, that the Scottish Government has ignored. We've had a lot of reports over the years about diet and why we need to change. And more recently, we've just had revised dietary goals for Scotland. And a new goal at the top of that list is a reduction in calorie intake by about 120 calories per day at a population level. We're continuing on with trying to get people to eat more fruit and vegetables, fish, limit the amount of red and processed meat, decrease sugar, salt. These targets have been with us for a long time. Many of us in this room have worked with them, and many of us have seen that nothing is happening at all. Now, we do, of course, in Scotland have a food and drink policy, which I was involved in, as was David Atkinson here, and we produced a report. Well, the government produced a policy document. We produced a leadership forum report, and the two are not identical. And one of the things that we said in the leadership report was the Scottish Government should recognise the impact of price rises in food in the poorest and put in place mechanisms to ease the burden, investigate options to develop social support schemes, look at pensioner food poverty, and promote community-focused activity. Bear that in mind as we go through what government are doing. In terms of food policy, we also have some perspectives well beyond Scotland, even coming out in academic and professional publications. This is from the British Medical Journal, Food Policies for Healthy Populations and Healthy Economies, written by Karina Hawkes. And I find this a very good model in terms of thinking of food and health policy. We need to think about consumers, that's people, that's citizens, consumer food environment, and food systems. So this will all be familiar to you in terms of when we think about consumers. Yes, we need to think about education in terms of information campaigns, dietary advice in a range of settings, food skills education. And when we talk about education, we really don't mean this sort of stuff that we see in labels, where we've got huge portion sizes recommended and really misinformation provided on the label. In terms of the consumer food environment, we need to look at reformulation, we need to look at nutrient standards, potential for food taxes, and make sure that our information and promotional environment is more consistent on dietary advice. And I had a look through the slides yesterday and saw this wonderful slide with the two triangles as to what healthy diets are recommended and what is actually rolls out in marketing. And these are just some of my marketing slides, because this is actually the environment that we live in. And this, of course, is W.H. Smith's in the hospital setting. And food and retail, we hear industry saying they're doing wonderful things. They're increasing healthy options, they're increasing the range of portion sizes, they're promoting fruit and vegetables. But actually, we need to think of the other things that are going on as well. So it's no good just to think about the positive. We need balance and a level playing field. Food taxes, I don't want to go into a discussion there, but what the evidence seems to say, and this is again another British Medical Journal, great to see food policy in medical journals, taxing a wide range of unhealthy foods or nutrients is likely to result in greater health benefits, but it needs to be at least 20%. And just as we think of taxes on an unhealthy food, we need to think also about subsidies on healthy food. Oops. Okay, again, going back to Karina Hawkes' paper, what about the supply food chain, which is the third strand? Food producers, processors, distributors, manufacturers and retailers have more incentives to produce, distribute and sell healthier products. Food producers have more opportunities to enter alternative marketing strategies for healthier products. And this is the bit that I think that we miss out on in terms of the government's health policy. And I just want to flag up in terms of what Scottish Government is doing with relation to food and health. Very wisely, they have a three-tier set of actions, putting children's health first. We invite retailers and caterers to remove all confectionery from till points, checkout aisles and areas around checkout. Good. We have a guide coming up for healthy options for children's menus, incentivise healthy lunchtime deals, and developing a beyond the school gate policy, because we know there's a lot of fast foods and so on sold around kids, tempting them away at lunchtime. All sounds good. Supporting consumers and communities, front of pack labelling, caterers to roll out calorie and extend nutritional information. We invite food industry businesses, primarily supermarkets, to join a stakeholder group to oversee development and implementation of our new health eating social marketing campaign, so working side by side with retailers. Formulating healthier products and menus, reformulation, so we have lower salt, sugar and fat in our products. Making sure that the Healthy Living Award has got some major adjustments. Inviting caterers to make smaller portions, ensuring that soft drinks with added sugars are only available in small portions, and maximising the Healthy Living Award, food standards. Oops, I don't think I managed to finish there. Oh yes, I did. I finished. That's good. Okay. Good. So let's just go back on that. We've got something about confectionery and tills, children's menus. We've got labelling. We've got reformulation. We've got portion sizes. Great stuff. but I don't think that's transformational change. And I don't think that it incorporates the whole producer-distributor network. I think we're focused only on education and a little bit on our consumer environment. And I think we need to work together, coming from health and disease, with the other food systems work, and put that together in government. One of the problems with Scottish Government is it isn't terribly joined up. I think the food and drink policy work was an opportunity to join, and we've lost it. We're now back into silos. So I think working together is how we need to move forward. So I'm going to stop there.
Thank you.
That was brilliant on timing. Thank you very much.
Okay, our second witness is Lucy Aitchison, who has worked as a manager in the charitable sector for a number of years, then completed an MSc and since completing an MSc in Environmental Science at Aberdeen University in 1994. She worked in conservation. She's a red squirrel conservationist originally at some point, but now I gather from staff team at Nourish that she's now more famous for being on Good Morning Scotland and Reporting Scotland with Broomhouse Health Strategy Group project was featured in the coverage around the Nourish conference yesterday. So I welcome Lucy.
Thank you very much. I can guarantee I'm going to give your eyes a rest because I've got 4 slides. I'm afraid that we had an extremely busy week last week, mainly due to the pictures down at the bottom. We celebrated our 20th anniversary last week, and we had a street party, a free street party for the local community. So my compilation of what I'm saying today was chucking a few slides together, going, there you go, slideshow. So I apologise. So a bit about us. Who are we? Broomhouse Health Strategy Group. We're a small community health project based in southwest Edinburgh, a recognised area of deprivation, Broomhouse, Sighthill and Parkhead, within the indices of deprivation, within the worst 5% within Scotland. The project basically started up 20 years ago. A group of 3 local projects, women's projects, got together and decided that they wanted to do more. Local residents wanted to do more to improve the health and well-being of the local community. There wasn't enough access to decent food, to decent fruit and vegetables. So they set up the Health Strategy Group, and their core the core activity at the start was basically a fruit and vegetable shop for the local community. And it's run by a voluntary management board made up of local clients, local volunteers and sector professionals that have an interest. So just to go over the aims of what we do, we promote healthy lifestyles within the local community by providing access to affordable food and undertaking food health activities. We work in partnership with local organisations to raise awareness, identify and address gaps in health services, in health service provision for the local community, and we set up self-help and support groups for the local community around identified areas of health needs, and we provide volunteering opportunities with the intention of generating greater confidence and self-esteem in those volunteers, and using an inclusive approach, we involve and empower local people to help determine their health needs. So basically we use the community development principles in everything we do. So really the core work is about making food more affordable and accessible. So I'm here really to kind of give an illustration of what Annie was saying, put into practice of how we try and achieve that. I was very interested by some of the slides you had about what the Scottish Government should be doing and perhaps aren't doing. Well, a group of volunteers in southwest Edinburgh are doing it without any input from that. They've worked out themselves what needs to be done. It's fantastic. So, in terms of the fruit and veg shop, so here we have, just to explain what we've got up here, we are the smiley fruit face. That's our shop front. It did look like that until last summer, when we got money from Dulux and repainted the whole of the market using free paints and money from Dulux, a huge community project. All those designs were designed by local children. You can't see, there's three huge other walls that have got big murals on. Please come up and have a look at it if you're in Edinburgh, because it just looks fantastic and it's really transformed the area. These, as I say, are pictures from the street party that we just had last week. So in terms of our fruit and veg shop, basically we're open every weekday morning. It's run by volunteers. We sell over £600 worth of fruit and veg every week, cost price, people coming in asking for half a cucumber, 2 tomatoes and 3 apples. It's that kind of quantities. That's what we're trying to get out to people. We don't want to make a profit. All we want to do is break even. We just charge 10% on cost price to make sure that happens over the year. So why are we so valuable within the local community? Well, it's helping those people in an area where not many people have their own transport. A lot of people are on buses, a lot of people are just using taxis, believe it or not. We have 2 huge supermarkets, sort of a couple of miles in either direction. People go there, they get taxis back in an area where people really can't afford, you know, the least likely area that they would be taking taxis. They go to the supermarket and they have to bring it back in a taxi, because if you've got, you know, if you go down there, you are going to make the most of the fact that it's a big shop. You can't bring 6 carrier bags back on a bus. We know what it's like unloading our trolley into the car boot. If you've got babies in pushchairs or buggies, how can you trundle 2 miles onto the bus or you know, walking and bring back those bags? So people come to us literally on a daily basis, and they buy in the quantities they need. So it's giving health benefits, not just in terms of getting them out and about physically, it's getting them out and about socially, but also from a budgeting point of view. They are able to spend the minimal amount getting the products that they need, and they're not being enticed by any of the bog-offs or, you know, buy big packs. They can literally get what they want. We also do, we exchange Healthy Start vouchers, and in fact we've linked up, the NHS have got a smoking cessation programme going locally, and they give out our vouchers as well. There is a food bank that's set up just locally as well. They give out our vouchers as well. So it's all ways to try and get more of the fruit and veg into the local community. So, oh, I use the blip, do I? Which one? This one. That's it. So this is inside the fruit and veg shop. When we did the transformation of the market, we also did a refit of the shop, which has resulted in a fantastic increase in the range of stuff that we can supply. Huge amounts of fruits and vegetables. We can order anything, whether you want a papaya, a star fruit, an aubergine or kohlrabi, you could order it one day and we could get it delivered the next day. We've got a relationship going with an organisation called Edinburgh Community Food, who actually were set up by the volunteers that set up our organisation. They deliver to, Edinburgh Community Food delivers to all the co-ops in Edinburgh. We're very fortunate, we're the only one in Edinburgh that has got the permanent shop front. And so they deliver to us every day. But now we've got extra space after the changes. We've now increased our range, so we sell staples like you know, noodles, rice, pasta, a lot of dried fruits, a lot of healthy snacks. We've got a whole stand of healthy snacks, from banana chips and nuts to dried mango and apple bits and all sorts. So it's really trying to give some really good alternatives to what's available just around the corner in the sweet shop. So who uses us? I thought I'd put just a little bit of information up here, just from our customer survey that we had done earlier in the year, when over a 2-week period there was over 100 people interviewed and filled in questionnaires. 60% of our customers don't shop elsewhere for their fruit and veg. 99% said they have a disability or long-term health impairment. This is reflected in these figures down here. This is the NHS diversity and equalities data that we got them all to fill in. Now, for the Gorgie Sighthill ward, that, according to the 2011 statistics, that should be 20%, is the recognised statistic for people with a life-limiting illness. We clearly cater for the most vulnerable in our particular area, because for literally nobody to say, I have nothing wrong with me. I was astounded. This is people themselves filling in this form. It gives you an indication of the kind of people that are coming to use our service. In terms of the recipe bag information here, soup bags, we do soup bags. These are fantastic. It's basically a bag that, because it's volunteers that run our shop, and we have at least 2 volunteers on every day, it's the small things that make the difference in terms of being able to make up soup bags that have all the ingredients. It's literally somebody will come in and go, oh, can I have a leek and potato, a butternut squash and a lentil and tomato soup bag, and they'll just make it up from stuff on the shelves. It's complicated because we have to keep an eye on the prices, because prices change every week, so we've got a crib sheet of what goes in that soup bag so that that soup bag can cost £1, and they get the wee recipe sheet in it that's a nice easy to follow recipe, and we've just expanded that range to include recipe bags, so it's a whole meal. So you could choose between lentil dal at 75p or tomato pasta, which includes a whole bag of pasta. I've forgotten how much it is at the moment, but it's about £2. It's, you can produce a very good meal. Admittedly, they're all vegetarian, but a lot of them have got pulses and beans in. So whether it's vegetarian chili, paella, sweet pea korma, sweet potato korma, or there's cauliflower and chickpea korma, stuff like this. And what we do is we've actually got, we've bulk bought all the spices, and the volunteers literally make up little teaspoon bags of all the different spices. So when they're making it up, they'll chuck in 1 stock cube, they'll chuck in 1 cumin, 1 coriander, give them the bag, everything they need to make a really wholesome meal with the instructions there. And people come, people try it, and we can say, well, if you want to put meat in, that's the bit on the recipe, that's where you'd be putting the meat in at that particular stage. So it's really building up confidence. We also deliver to schools. We have three local schools that use us to get, it's called the Healthy Bag scheme, where we say to them, choose your varieties of soup, fruit or smoothie bags, because we also do smoothie and fruit bags for £1 each as well. And the kids, it's great because the teachers have got the kids to be involved in going around the school, taking the orders, collating the orders, so it's a whole educational thing with putting that together. And then also we have a free home delivery service when we have enough volunteers. If people phone up, we've got a few regular customers that are housebound, and we will get the stuff taken down to them. Oh, wrong way. So, none of it would be possible without the volunteers. They are the key to our organisation. Literally over the last year, for the mural project on its own, we had 78 volunteers taking part in that over a period of nearly 3 weeks. Outside the mural project, just purely in the running of the co-op and our associated services, we had over 40 volunteers. So we have a steady turnover. We're victims of our own success. We had 17 new people join us last year, and we had 18 who left us. Now, half of those who left us to either go on to employment or on to further education, which is fabulous, which is great. We've got our Investing in Volunteers Award, which is a real benchmark of the way that we treat our volunteers. And what I want to do is go on to the cooking side of our service, because naturally, when you're selling fruit and veg like this, people come in, when I first started 4 years ago, I was astounded when somebody came in and said, so how do I cook? How do I bake a potato? And you realise that there are people that will come and really are needing, just to have that little bit of confidence given to them in how to deal with, with cooking things. We held a soup workshop at one of the local schools to launch the fact that we were going to start selling these soup bags for £1. And the response to that was so incredible. Just, cooking a pot of lentil soup at school with parents, we realised that there was a huge need with people wanting to gain the skills of just how to cook healthy food on a budget at a very simple level. So, don't know what's happened to that photo, never mind. Before I actually come on to the cooking, I realised within the time I've got, I haven't got time to talk about, I'll talk about our cookery service, but we also run a time bank, we also run health drop-ins, we run a walking group, we have regular open days and promotions. For example, after we had the, once we finished the shop upgrade, we had a fortnight's promotion where we got Community Food and Health Scotland money to do a bit of a promotion. In 2 weeks, we sold over 260 soup bags. We sold them at half price, so they were 50p instead of £1. 260 we sold in 2 weeks, and over 50 recipe bags with the whole meals, just to show people what they could now get, because that was the start of us selling the recipe bags. So in terms of cooking, following, that we have held over the last 20 years the occasional cookery class. We now know that it really is very much needed to renew people's skills. We are very much client-led in knowing what they want to cook. They can come in for a range of reasons. We have people that men can come to the classes, and we've had examples where they've suddenly become the main carer because of either losing a wife or because their partner's suddenly got some illness that's very life-limiting, and they haven't any idea whatsoever. And some of the stories we have are really quite amazing. One gentleman's come in, lost his wife, was very low in confidence and belief in his own abilities. He's now helping to volunteer at the local lunch club in the local church to help cook a meal for 20 people every month. And it's things like that help to grow the community. We're trying to show that people can cook the foods they like. There was the slide of the fast food outlets is really quite scary that Annie showed, and to be able to show people how they can cook. You ask at a cookery class, what do you like, and they will all list all the takeaways, and you say, well, do you know how to cook them? No, never cooked one. They've no idea. So showing them how to do that in a simple way. But the issues around certainly the cooking, it takes time and it takes money to make these changes. If you advertise a cookery class in an area of deprivation, your door isn't battered down by people wanting to come to a free cookery class. People with low self-esteem are very, very wary and reluctant to come into a class. They don't know they don't know the leader, they don't know the other people that might be there, they don't know the room, they don't know the setup. So you have to lead them. Sometimes we've had to show them the room empty. This is where we'll be cooking, this is what it's like. But the difference, the gradual change that you can have when people do come and you see the difference it makes to their own self-belief. They have very chaotic lives, and giving them the ability to feel that they're in control of at least one bit of it, what they feed themselves, really helps them on the road to greater self-belief, self-confidence and control, ultimately better control of their lives. We make sure there's no literacy issues. We don't use written recipes until after the classes, because literacy can be a real barrier. We don't use weighing equipment. We use cups, a dot of this, because people, they won't have scales in their own home. So it's making these recipes simple, easy and accessible. Everything we do in terms of trying to make people eat and cook more healthily is about making food more sustainable for them. But for us, the key driver is health and budget. I would love us to have more local food. We get local food because we are supplied by Edinburgh Community Food. If they can source the local food, then we will by all means use it. They have to balance the issues of cost, of locality and quality. Our prices change on a weekly basis, so they are in continual negotiation with where they're going to get the best deal. So in some ways, we don't have the capacity to make significant changes in going local, but ECFI, by working with ECFI and pressurising them and seeing if there's ways that they can link into more local food networks, then yes. But I know they will be doing that, but there's perhaps more ways that can be done. Really, just to summarise, we are in a very unique position to have permanent premises and, most importantly, willing volunteers and these good suppliers for our fruit and veg. Without any of these elements, we wouldn't be able to do the work that we do. I hope you found that interesting, and thanks for your time.
I always really love practical things that are actually happening rather than thinking about what we might be able to do. That was fantastic, thank you. Right, our next speaker is Dr. David Reilly. He's the director of the WELL programme, which I've got a very big, long description of what that does, but what stands out for me is that it's about, it says here, enabling people to use the knowledge they already have about what's best for their well-being. So I'll let David talk about that.
Thank you. Hello, everybody. Thanks for letting me be part of the conversation. This is my daughter, Karina. When I was her age, obesity was about 3% in this country, and I'm not 200 years old. Yeah. It's increased tenfold. And what's to become of her, and what's to become of our children? And are we, even with our collective best efforts yet, hearing the vision and the solution for that transformation? And probably not, I think, is our consensus. We were trying to build this conversation and build this change. And as Annie said, these epidemics, which are literally epidemics that we're trying to deal with, are not, as some rationalise it, epidemics of old age, as diabetes now appears in school children, primary school children in Scotland, coming to amputations by the age of 20 at this stage. And this is the week, isn't it, or so, when Martin Luther King gave his speech. He didn't begin it, I have a complaint. We do need a dream, and it's quite clear that if what we were doing up to now was good enough, we wouldn't be where we are. It's a simple statement. Therefore, if we want this transformation, we actually need a transformation in our own vision. And I think this is true at both the cultural level and then down at the personal level. And I'd just like to share a few reflections with you about that. About myself and my colleagues are working what we're calling the Healing Shift inquiry. How might this shift and transformation be brought about? And I'll finish in the second half by illustrating a little of a model that we're using with people, which seems to be working well for a lot of people to achieve this shift that they're after. Because the suffering is immense and the search for a new way is intense for us. We saw those people from Annie's slide about the statistics of likelihood. So here's 25 people coming in to the WELL programme, W-E-L, Wellness Enhancement Learning. As you can see, they capture the spirit of what we've been hearing this morning, and the fact that if you've got one long-term condition, you've most certainly got more than one. And to repeat, if our model was working, these people wouldn't be in this predicament and wouldn't be joining this group. And it's within the NHS. The groups have been running since 2004 and going through iteration and research, and now moved into primary care. These people have been referred by the general practitioner because of the intensity of the difficulties that they're facing. And it's not just they who are facing the difficulty. Primary care, an average of 9 minutes an appointment at the moment. And what would you do in the face of these epidemics? Meeting someone for 9 minutes. Oh yeah, well, I've lost the will to listen. Burnout is rife amongst health staff. And yet, for many people, they are the people whom we go to and to saying, how might I flourish? Yes, how might I deal with the modern world and these epidemics and this challenge to health? And the truth is, of course, they're meeting people who mostly not only don't have the answer, but who are themselves caught in the epidemic. I don't say that to put anyone down, just to be honest about it. Here's another group, same sort of story, high levels of mental stress, about a third showing metabolic syndrome manifestations probably, but here's the thing, they're staff. Okay, and they're the staff who are still working. So we don't have the answers, and we're not living the answers, so many of us. And I think we have to confront this and be honest about it. The search, The search for the shift, for ourselves, for our families. And the density of this predicament is well rooted. You know, it's in 200-300 years of a perspective that we need here. With the dawn of the industrial age and the Enlightenment and the scientific revolution and the arrival of cities and urbanization, we can go back to the 19th century and see at the beginning of it, people were eating 4 pounds of sugar a year, and at the end they were eating 100 pounds of sugar a year. You know, sift flour appears in the early 1800s and the steel rollers in 1870. Margarine's invented in 1870. Take Glasgow at that time, rife with rickets and scurvy, and the kids in deprived areas 6 inches smaller than in the middle class areas. And cholera killing thousands of people per year, 4,000 a year sometimes. This has got deep roots, and I don't think we should be naive about that. And to try and navigate these public health challenges, we've been using a map as a culture and as individuals. We use these subconscious maps. And here's what the map is. We may not even have brought it to conscious awareness. It's an outside expert who steps in to stop things happening. Yes, that's the dream. And it's a wonderful map, and it helped build the modern world and make such contributions. You know, it gave us the idea of the clean water supply of Loch Katrine, resisted for 25 years, that dropped the cholera deaths down to 85 the year after it was introduced. When people said the vision was not possible, it was part of human predicament, it was the way people lived, it's just an inevitable consequence of modern life, it can't be done, it's too expensive. Yes, and it was done, and the impact came. And I won't speak of the other fantastic contributions that these waves of public health and science, of this expert knowledge being applied, have brought to us. And yet we sit at the predicament we're in, where the world has changed and the map hasn't. And so I think it's as deep as that. And just trying to do more of the same and shout louder about it and tell people what to do and get better labelling and better information out there and better facts from the experts, it's not doing it. It's not doing it. So these are slides that are shared with people in the WELL programme. Until it's presented to them, this is true of you as well. You're caught in this predicament and you're not finding the answers from your government and from your healthcare workers. And therefore, what does that mean for you? What do you do when you have diminishing returns like this? We're searching for a fifth wave, if you like. We're looking for this new vision. Where do we look? You're too fucked up. Next. Under the floors where I started to look in the 80s, working in the pain relief clinic at the Royal Infirmary, I worked with people for whom the system wasn't working. My toolkit was bust, the map didn't work, and there was no solution. And I had to fling it away, and I had to stop seeing the brokenness in people. I realised I was trained to see people's brokenness, whether it's in the person or the system, and think how to fix it. And I had to undergo a shift before I could help them. And that shift could be characterised as seeing the strength in the individual, in the community, and asking a different question. Not how can this be fixed, what can we do to sort this, but how can this strength be released? And how can this individual find their own strength and be supported into a self-sustaining discovery and growth of that strength? And that's the very heart for us of the shift that we're speaking of. And I represent it here, if you like, as this little seedling. So the people that come into this programme are not there to be given fix or just given facts and information, because actually there's information overload. It's quite a different approach. And the study, if I place that at the very centre of our vision and inquiry, for 15 years we studied the self-care relationship and how it can be modified in the caring relationship with another. This was from one-to-one encounters, videoed and analysed and studied. And then the principles that were learned were scaled up into group work in 2004, which is the WELL programme that I'm mentioning. And now, all along and increasingly, is then part of a larger conversation of the fifth wave. How can what we're learning be scaled up to the level of policy and nation? And that, I think, is our question together. And we've just heard from Lucy, what an amazing story, yes, of a community finding its own strength rather than solutions being given to it. And Annie's acknowledgement that the good ideas that were presented will not be enough and will not bring the transformation. So this is the shift of which we're referring. I'm working with a sister project called the After Now Project, which is looking at public policy and cultural influences on well-being. And I can commend the website of After Now to you as being part of our sister work. At the heart, then, is this built-in capacity of strength within someone. And if you're not dead, you've still got it. That's the way of it. You know? So bring them in the wheelchairs, bring them in as need be, because if your heart's beating, something's going on there. And with skillfulness and awareness and the right deep vision and understanding of change process, stuff happens, I would say. And you'll see this isn't an outside-in evidence-based model that's been so dominant. I would call it a practice-based evidence model, as increasingly the dialogue is beginning to encourage. If that was a few brush strokes about that larger origin and vision that informs this, the WELL programme, of which I'll now say a little, is not presented as some big solution that everyone should be doing. It's a modelling of these core ideas and the distillation of principles, we hope, that we can maybe share and be part of the conversation together. So what does it consist of? About 16 hours for most people, and the core of it, the question I hold and the other group facilitators hold, and the person's brought into the space to consider, is this activating the self-care. And if you don't get that, it won't sustain and it won't work. And what does that change take? That becomes the inquiry. This is a study in change process rather than imposition. And yes, there's toolkits, mindfulness and meditation and information on food and so on, but it could be a different toolkit. Because when someone's activated at that level, they'll seek out the information actually, begin to start to absorb it, like a plant putting its roots down, to gather the information. And so like a gardener doesn't know how a plant grows and actually doesn't make it grow, a gardener sets the conditions for growth. This is a study of the conditions for change. And one of those conditions to touch on briefly is, of course, you can't create a world that differs from your inner map of the world. It's simply not possible. And it doesn't matter how much hard work you put in or how much determination you've got, you know, how many health clubs you join, how many diets you go on, how many books on your shelf. If there hasn't been this inner shift in the map, there won't be sustained change. And this is not just a psychological thing. As we now know from the new science, the more you think a thought, this is actually a nerve being myelinated here with layers of myelin. It's built from omega-3 actually. Yeah? And so the patterns become embodied, physically embodied in reflexes in individuals. So this is no simple matter. As one of the participants put it, you know, we're talking about 40 years of habit here, deep into the body and deep into the mind. And so engendering a mindful awareness becomes important. Beginning to observe what one does. People fill out, for example, between part 1 and 2, they just track what they've eaten and had to drink in the previous week. And there's an atmosphere created that I don't have time to maybe describe its creation, but it might come to a simple question. Would you feed your dog the way that you've got on that bit of paper? And you know what people, no, I wouldn't dream of it. Why not? It would make it sick, it would be cruel, it would be unkind. So entering this creative space and the use of metaphor, as we found, is very critical and extremely helpful, but only from someone that you trust. This growth in mindfulness then spreading to other members of the family. People learn of the capacity of human beings for strength. Here's placebo. This is antidepressants waking up the left prefrontal cortex of the brain. So does placebo response. This is the inherent power in human beings. Teach people certain forms of meditation and they can wake these centres up, their own antidepressant centre up. And one of the meditations we teach has been shown with a good research base to be able to begin to build that skill. This is skill-based, of course. This is myelinated pathways over time. These are not quick fixes. And a key that I'm hinting at then is that it's this care environment. Has the practitioner undergone a shift? And are they capable of producing the safety and relationship and empathy and inspiration that would then be required for change process. Empathy is a key in that. Without empathy, you just don't get there, as the research is showing. So it's not so much the what, it's the why. The why bother? And I think self-compassion lies at the core of this. Truly, most people would never dream of treating an animal the way we treat ourselves. And it's not just physical nourishment we're talking about. In some ways, that's the least of it. This is emotional nourishment. And are you living a life that's actually balanced and causing you to flourish? Or are your words empty when you go and speak of it with others? You don't have to have reached a destination, but are you journeying? Are you just genuinely journeying with it? When it comes to the food, confusion abounds, doesn't it? Absolutely abounds. So, and of course, thank God we've now got government guidelines of traffic lights. You can't see the reds and the greens here, but I'll read you them out. If you follow the traffic lights, what's all green? Coca-Cola, shredded wheat, white flour, white bread. What have you got reds on? Olives and mackerel and sunflower seeds. How are you doing with that? Yeah? So, here's to summarise the lecture that we can give. You ready? In fact, I think I'll just give you the lecture now. So, it's part 2. You've got ready. You've been confronted about your self-care relationship. You're beginning to be consider a mindful a watching of what you're doing. You make yourself ready for a discussion on food, and I say, okay, here's the talk, here's the lecture. The lecture is eat food. I say that's the lecture over. Yeah, but what's food? When you ask people what food is, and you know their mind's so in left brain now, it's nutrients, it's things that build the body, it's vitamins, it's minerals. No, that's not going to guide you. Food is something which is alive or was recently alive. That's what's put to people. And if you eat that, you'll be fine. So we do a wee quiz, and people figure out what's more food, an orange or white bread, or an orange or orange juice, or sugar, or a Mars bar, or a deep-fried Mars bar. Yeah, and they figure it out for themselves. And yes, then some information's given, but that's not really what it's about. And people have a big wake-up call, and they suddenly start looking at the supermarket trolleys and other people's trolleys, and they've got a compass. Now, okay, I've summarised that in a minute, and people have up to about 3 to 4 hours on food and nutrition and on the effects of moving from a traditional diet to the distortion of a Western diet. And my time's up, and maybe if I could ask you to consider, if you're interested, going on to the website and having a wee look about what we're up to. And let me just flash a few results, because we've got a quite intense tracking. Great feedback on this course. This is psychological well-being tracked over 9 months, double baseline, and then rising and sustaining itself. Fatigue improving, self-compassion substantially rising, as multiple groups showing the same thing. People transforming what they eat now in a self-activating way. And then highly encouraging changes in objective measures like omega-3. You know the target's 40% should be omega-3 versus omega-6. Well, do you know only 8% of our cohorts are even reaching the minimum 40%? There's the epidemic of the future. And yet 2/3 of them, at 3 and 9 months, self-activating into change that's improving it. Same things happened with vitamin D. 2/3 of them are deficient or insufficient. Almost all correcting. No deficiency at all after 1 year follow-up in the results that we've just had. But to finish with, the toughest bit of all is the addictive foods. And that's, I think, part of the problem we're up against. As you know, sugar is being shown to be more addictive than cocaine. This is no minor matter. Okay. And we've been doing fasting insulins and seeing that certainly 1/3 of people on that measure are already pre-diabetic. and up to 45% are in the suspicious or frankly pre-diabetic range, which is just horrific, isn't it? But they can do it. They can start to drop these levels, and at 3 months, still do it. But early data on small numbers at 9 months may be showing some tailing off. And the last bit I want to make, and I'm sorry that I've taken 2-3 minutes extra, is the link to the fantastic work that we've seen in the previous talk. Because what we are not adequately doing is giving sufficient follow-up in the community and sufficient mobilization of community resources. And people are up against the issue of the cost and up against the issue of the addiction. And on Monday in the town of Nairn, where we've been piloting this, we're now going to hold a civic conversation, which there's been 30 seeding conversations in the community. And then we've hired the community hall and we're bringing the community together, in which we're going to ask them their guidance and their input and ideas of how we might now grow this as a model. Thank you very much.
Thanks very much, David. What I should have said, actually, when I introduced David, is that he's today's bog-off deal, because he actually came with reinforcements, Kath Cooney there, who chose not to speak, I gather, so it wasn't a double act. But in the spirit of our investigations later on as teams, I don't know how long they're with us today, but Kath is...
Just till the end of lunch.
Okay, fine. So this morning, Kath is also available for the groups to call upon to give a bit of input if we need that. So thank you for coming, Kath. Right, so we're going to tea and coffee now, and then I will be going off to a team like the rest of you. So let's see, we've run a little bit over, so say at 11:20, we'll be going to our team rooms, so you all know where you are. And then the rest of the session, we are breaking for lunch at 12:30. We're coming back together for tea and coffee at 3 o'clock-ish, and then we've got the plenary session at 3:30, when the teams are reporting back. So you're now for the rest of the day in the hands of yourselves and your facilitators to structure how you come up with your reports. So enjoy.